Hi, my name's Ayleh. I'm a fourth year medical student, and today I'm going to be talking to you about laparoscopic sleeve gastrectomy. So, I'm going to be discussing the indications for it, a bit about the history behind it, the advantages and disadvantages of using it, the equipment used, so the laparoscopic equipment used, the operating tables used, and especially for bariatric patients, and the main steps used in this procedure, in this surgery. So first of all, I'm just going to cover what laparoscopic sleeve gastrectomy is. So a sleeve gastrectomy is, as you can see um, in this uh, in this image here and this image here, is essentially where you cut um, vertically across the stomach to leave the stomach in a smaller size. So there are many different types of bariatric surgery, and one of the types being sleeve gastrectomy, and this is what we're going to be focusing on today. You've also got gastric band. You've got a gastric bypass, you've got a BPD, and then you've got a BPD switch. So we're not really going to look at any of these apart from this one. And the history behind it is that the sleeve gastrectomy came about as the first step of the BPD switch. So the BPD switch, the first step is to perform a sleeve gastrectomy to ensure adequate weight loss for the patient. And then the second step would be to, as you can see from the image here, join the end of the intestine to the duodenum. So in 1999, they realized that they only have to perform the sleeve gastrectomy, so the first step, on some patients, and that is how it came about. And most of the time, it's performed laparoscopically, so via small incisions into the stomach, into the abdomen, and then the laparoscopic instruments will go through the ports that are placed in the small incisions, and then the surgery will take place. So here is a cartoon of what a sleeve gastrectomy is. So as you can see, the stomach is cut vertically in an 80-20 fashion. So one of the surgeons that I spoke to said that he cuts it in an 80-20 fashion, and he approximates it roughly. There's no measurements, he just is by experience where they know where to cut. And they also use an equipment called a bougie, or a boogie if I'm pronouncing it wrong or correctly, to guide the stapler where to cut the stomach. So we'll talk a bit about that later. So we've covered the history. So it's performed in 1999, the first one. And initially it was used for a BMI of over 60. And as we talked about, it was the first part of the biliopancreatic diversion with the duodenal switch. So BPD switch is the first part. So nowadays, the indications to perform a laparoscopic sleeve gastrectomy is if the BMI of the patient is over 40, or if the BMI of the patient is over 35 with at least one comorbidity that's obesity related, such as hypertension or diabetes. The third indication is if the patient has tried to lose weight over a certain period of time. So I think in the NHS it's a year, but or longer. And if they can't lose weight and they tried all the diets, they tried exercise, and they still can't lose weight, and they add a very high BMI, then a laparoscopic sleeve gastrectomy will be considered. And recent research and recent updates have shown that BMI of 30 to 35 with uncontrollable type 2 diabetes or metabolic syndrome is also an indication to perform a laparoscopic sleeve gastrectomy. So there are advantages and disadvantages of using a laparoscopic sleeve gastrectomy over the other types of bariatric surgeries which we saw here. So the advantages is that it's very, very fast. So you're cutting away 80% of the stomach, or in some surgeons' cases, 80%. Majority is 80%. So you're cutting away the stomach to leave only a very small part left. So it'll be a very dramatic weight loss. It's also a shorter procedure time, and because it's laparoscopic, it is a shorter procedure time and safer for high-risk patients. You're not cutting open the whole stomach. There's less scarring as well. And it decreases the risk of long-term nutrition deficiencies compared to other bariatric surgeries, such as the gastric bypass, which we can see in the image here. But the disadvantages is that it's irreversible, so you're cutting away the stomach, you can't suture it back on is cut away. It can also cause GORD, so gastroesophageal reflux disease. So if someone has GORD already, you'd think twice about performing the surgery, and then maybe a different type of bariatric surgery would be more appropriate. And the gastric bypass surgery can be more effective in metabolism than sleeve gastrectomy. So the main takeaway is that it's a very, very fast surgery, dramatic weight loss. Disadvantages, it's irreversible. So the laparoscopic equipment used, there's a fair bit on the slide, but it's pretty simple. So we'll start from left to right. So in the image, not sure if you can see with the mouse, but circling it is the stapler. So as you can see, there's like blue crisscrosses, like looks like string. So that string is pulled, and when that string is pulled, the staples staple on. And underneath the staples, you have this white material that you can see on the side of the stapler, and that's called buttress material. So we'll talk a bit about that later at the end of the talk. But buttress material essentially enhances the staple line, so making the staple line stronger, as it just adheres the two sections being stapled together. So you've got the laparoscope. You want to angle that at 30 degrees. So the laparoscope is just the camera that's put in one of the ports, so you can see it inside the abdomen. You've got the monitors. You've got the Nathanson liver retractor. So this massive contraption is attached to the table, and then so someone doesn't have to hold it, and then the Nathanson liver retractor is inserted into the abdomen and pulls back the lateral left segment of the liver. You've got the flexible endoscope. So I'm working just my way to the right at the top. So the flexible endoscope, as you can see in the image, and that looks intraluminally. So it's placed in the mouth, in the esophagus, and then down into the stomach to see at the very end of the surgery if there are any leakages. And then you place these ports. So the top right corner, you've got different sizes. So we'll talk about today the 5mm ports and the 12 to 15mm ports and the 10 to 12mm ports. So they're all different sizes in diameter. And they, once the incision is made in the abdomen, you place the ports and then you can place your laparoscopic equipment in. So if you go down here, so underneath the port image, you've got the laparoscopic instruments, and these are placed inside the ports and used to hold the stomach and rotate everything, just like a pair of hands in there. And then you've got the drapes. So the drapes cover the patient's abdomen and only expose the part that you're going to do surgery on. You've got the carbon dioxide machine. So we use carbon dioxide. And carbon dioxide is used because it's inert and it's absorbable. And oxygen is not used because it's flammable. So carbon dioxide is used to induce pneumoperitoneum to allow air to fill in the abdomen so we can view it. And then you've got the laparoscopic energy device. So some surgeons use the harmonic, some surgeons use the bipolar. So harmonic that uses ultrasound energy to cut away at the tissue, whereas bipolar uses electrical energy to cut away the tissue. And then you've got in the middle the bougie, 32 to 40, so that's the size. So you can get it from 32, you can get it to 40, bougie or boogie. So this equipment goes into the stomach, and it goes into the part of the stomach that you want to keep, and then you staple around that piece of equipment, and it just guides the size that you want to cut. So in terms of bariatric equipment, so this is a cartoon of the bariatric equipment used. So you've got the multi-axis arm board. So you need lots of straps because the patient is in a position called reverse Trendelenburg. And reverse Trendelenburg is where they essentially are sliding down, and you don't want the patient to slide off the bed. So you need to have lots of straps and appropriate equipment and appropriate table sizes used. So you've got the multi-axis arm boards. So these are arm boards that allow the patient's arms to go out. The patient arm positioning is very important. You don't want the patient's arms to be positioned in towards their body medially, as that can increase the risk of a brachial plexus injury. So you want the patient to have their arms placed outwards. And these are secured onto the side rails. You've got the bariatric operating table, So you can either get 2 conventional operating room tables placed together, or most commonly in bariatric surgery, you get a special type of bariatric table, which I'll show you images on the next slide. And these take a larger mass. So as you can see here, a conventional table can take a maximum of 250 kilos, whereas a bariatric table can take a maximum of 455 kilos. And this accommodates for the larger width and the larger weight. You've also got the bariatric table extension. So this allows the patient to have their legs extended onto the bed and not fall off. You've got a split leg to induce a split in between the legs. And then you've got the footrest. So the footrest prevents the bariatric patient from sliding down off the table as they're placed in reverse Trendelenburg. And then it's attached to these clamps or Clark sockets. So essentially just clamping the footrest to the table extension. And then you've got the knee restraint straps to prevent the patient from sliding. And here are images, just some images to demonstrate the type of equipment used. So you've got bariatric tables, you've got the foot extension, you've got the thigh straps, you've got the knee straps, and then you've got the accessory cart for all the extra accessories, such as the knee straps and the thigh straps. So there are some contraindications to performing a laparoscopic sleeve gastrectomy. So absolute is if they cannot undergo general anesthesia. So all laparoscopic patients undergo general anesthesia for sleeve gastrectomies. If they've got uncontrollable coagulopathy, so they cannot form clots, and they have excessive bleeding, that can be a very big issue, and you would think twice about doing a laparoscopic sleeve gastrectomy. And if they've got severe psychiatric illness. And as we discussed before, if they've got severe GORD, you would think to hold off on doing an LSG being a laparoscopic sleeve gastrectomy. And if they've got Barrett's esophagus as well, as the acid can induce lining changes in the esophagus, causing Barrett's esophagus or making the Barrett's esophagus worse. So before we get on to the anatomy and the steps, so there are complications such as bleeding, leakage, stenosis, hemorrhage, major organ injury. So say the liver retractor accidentally stabs the liver, that could be one, or the laparoscopic instrument or the harmonic accidentally burns a different organ rather than the, say, omentum that is cutting off, or the stapler accidentally staples a different type of organ that you're not supposed to staple. DVTs, strictures, and GORD, and some of these can lead to sepsis, prolonged hospital stays, malnutrition, and death. So I just want to talk a bit about the anatomy before we move on to the steps of a laparoscopic sleeve gastrectomy, as the anatomy is extremely important to understand. So what I want to point out is the greater curvature, which you can see on the top left image, the lesser curvature, which you can also see in the top left image, the pylorus, the body and the fundus, and also on the bottom left, the antrum. Sorry, bottom middle, the antrum as well. So pylorus, antrum, body, fundus are the main parts of the stomach, and then the cardia as well, and the incisura angularis. And we also will talk about, which is very important for the where the placement of the staples are. So again, I just want to talk about the anatomy of the blood vessels. So just to note, the short gastric arteries in the left-hand side image, and the left and right gastroomental or gastroepiploic arteries, as they're also called. We want to divide and seal these to prevent excessive leakage. And on the right-hand side, this way, you want to also note the lesser sac and the greater sac, as those are where the laparoscopic instruments will be placed, and the greater omentum, the stomach, and the lesser omentum. So the greater omentum is what we'll be cutting through in the laparoscopic sleeve gastrectomy. So before we move on to the steps of the LSG, we want to talk about the pre-op assessment. So the bariatric patient will be reviewed by the MDT. So some people in the MDT would be the nutritionist, dietitian, the endocrinologist, the psychiatric specialist nurses, the surgeon, the anaesthetists. And then you want to prevent the risk of pressure sores and neural injury. So you want to make sure you pad sufficiently all those areas to prevent this from happening, as they have increased weight. So we talked a bit about this before. The positioning of the patient is in this cartoon here, in this image, and it's reverse Trendelenburg. So Trendelenburg is when you actually place the head down like that, but reverse Trendelenburg is when you place the patient sliding down, and you want to make sure they're sliding down to prevent a lot of issues that bariatric patients can face when they're on the operating table supine. So we place them this way. And the reason for that is because if we place them supine or reverse or Trendelenburg position, like with the head down, you can get compression because of their weight onto the diaphragm, so compression of the diaphragm, which causes difficult ventilation. You can also cause compression of the aorta and inferior vena cava, causing reduced blood flow, and you can also cause respiratory issues and a reduced FRC. So via an anaesthetic point of view, what we want to do for the patient is we want to first intubate them. So we assess intubation, how easy or difficult it is, by doing an intubation scoring. So this is looking at the neck circumference, and you don't assess the intubation on the weight or the BMI. You assess it via this score called the Malampasi score. So a score equal to 3 or over 3 indicates a potentially difficult intubation. The positioning of the patient's face, neck, and chest is also really important. So you want to make sure you stack their head, or it's called stacked or round position. So stack them with pillows or blocks or blankets to ensure that their chin, the tip of their chin, is placed at a higher level than their chest, as you can see in the diagram with the lines, the red lines, and that the patient's ear is placed at the same level as the sternum. And this allows easier intubation. So with intubation continued, you want to make sure that the patient reaches an oxygen, a partial oxygen of 100%. And you also want to induce and maintain general anesthesia with medication. So the most common is propofol. You can also use other ones as well. And you give that via cannula rapid IV access. Then you will also give succinylcholine, which is used alongside propofol is a depolarizing muscle relaxant, allowing easier laparoscopy, as seen here. And you want to have a cricoid pressure as well. Then you want to ventilate the patient. So we talked about why the reverse Trendelenburg position is very important. It increases the FRC, and it also prevents decompression of the diaphragm. And you also want to ensure alveolar recruitment. So atelectasis is very common in anesthesia. So you need to make sure you have a high sustained positive airway pressure, and this will re-expand the atelectic points in the lung, so the collapsed part of the lung, and increases the end expiratory lung volume. So now we'll move on to the steps of a laparoscopic sleeve gastrectomy. So the MDT are the surgeons, the anaesthetists, the scrub nurses, the first assistant, and you can also have a second assistant and other nurses as well, and other anaesthetists. So the first step is you want to induce a pneumoperitoneum. So this just means putting air under the diaphragm to raise the abdomen inside, just to have so the surgeon can have a look and see what they're cutting. So put air under the diaphragm, and you want to use a Verus needle placed in the left upper quadrant via a stab incision, and you want to make sure it's at 15 millimeter mercury. And then you place the trocars in position. So before we move on to the next slide, which shows the trocar placements, I just want to point out the important planes and lines that we place the trocars. So the purple line here is the paramedian line. So that's where one of the trocars will be placed on the other side, on the right side. And then the anterior axillary line is where you place the other trocars. So there are many different ways that surgeons place trocars. So this image is not a blanket statement, but it is the one that I found that most surgeons use and the surgery that I watched. So the surgeon is placed on the right-hand side and the assistant is placed on the left-hand side. So you put the Nathanson liver retractor, A, in the left upper quadrant. So it's the subxiphoid area, and like I said before, it retracts the left lateral segment of the liver. And then you place a 5mm port. So before you place the ports, you put local anesthetic in each of the sites you want to place it. Then you make an incision, and then you place the ports. So this is in the left anterior axillary line. So as we can see in the cartoon, left anterior axillary line, B is placed in that. Then you place the camera port, so a 10 to 12mm port, and this is just above the umbilicus towards the left. And then you place the 12 to 15mm port just above the umbilicus to the right, and this is parallel to the lesser curvature of the stomach. And then you place the other 5mm port, so E, into the paramedian, upper paramedian, mid-clavicular line. So A is the Nathanson liver retractor, B is an assistant port, and that's where you place the laparoscopic instrument. C is where you place the laparoscope, so the camera, so you can see. D is also an assistant port, and also where you can take the transex's stomach out. So once you cut the stomach, you can take it out because it's the biggest, largest width. And then E is the assistant port, so you place the laparoscopic instruments there as well. This is a cartoon just to illustrate what I've just discussed. So the surgeon's placed on the right-hand side and the assistant's placed on the left-hand side of the patient. And then you've got the monitors and the anaesthetist, and then the patient in the middle. So now you've placed all your ports, you want to also ensure that they're, like we discussed before, in reverse Trendelenburg position. So that should say angle, not angel, of 30 degrees, and make sure the patient's arms are stretched out to prevent a brachial plexus injury. And now you want to decrease the pressure in the pneumoperitoneum to 8mm mercury to prevent any physiological effects associated with pneumoperitoneum. And then the surgeon, the anaesthetist is going to decompress the stomach via an NG tube. So once all that's been done, so now we've put the ports in, we've induced pneumoperitoneum, so you can see inside the stomach, and you've compressed the stomach via an NG tube, and the patient's all asleep under general anesthesia. You now can start the surgery. So you place your laparoscopic instruments in, you place the harmonic or the bipolar, which are the energy devices which you use to cut away tissue in. You place the laparoscope in, and the anaesthetist is monitoring the patient's vitals. Now you can start cutting away. So you want to mobilize the greater curvature. So you have to first identify the pylorus, then you lift the stomach up as shown in the cartoon, and you then position the harmonic between the body and the antrum of the stomach. And then the surgeon is going to start cutting away using the harmonic, or it could be a bipolar, cranially. So this image here, D, I've drawn the red line arrow. So where the flat part is where you place the harmonic, and then the surgeon dissects the greater omentum along the greater curvature where the red line is, cranially towards the fundus. And this is just to mobilize the stomach from the greater omentum. And then the second part is, so they've now cut the greater omentum up, you want to cut the greater omentum down. So where the arrow is, you start at the midpoint between the antrum and the body, and then you use the harmonic and dissect the greater omentum 2 to 6 centimeters proximally to the pylorus, as shown in green. So that's just explained on this slide. So once you've now dissected away the greater omentum from the greater curvature of the stomach, you want to divide and seal the short gastric arteries and the gastroepiploic or the gastromental arteries. And the diagram is here so you know where the arteries are. So we've mobilized the greater curvature as discussed. Now we want to make sure the posterior side of the stomach is mobilized. So what you do for that is you take your laparoscopic instrument and you grab the greater curvature side. So you can see the greater curvature is, I don't know if my mouse is here, but you can see it there. And you twist, as shown in the diagram, you twist and retract the stomach. So now you're looking at the posterior side of the stomach. And this is going to ensure that we can cut away, we can staple away. And then you also divide and coagulate the superior splenic vessels. So the NG2 that was used to deflate the stomach is now removed. And then you want to now start stapling. So we discussed the staples before. You are going to use a 16mm endoscopic stapler in the 10 to 12 millimeter assisted trocar. So that, if we go back, a 10 to 12 millimeter, oh, sorry, it can also be a 12 to 15 millimeter trocar. You can put the stapler in there. So the placement of the stapler is the same as the placement of the harmonic. So it's in between the antrum and the body, so 3 to 6 centimeters away from the pylorus. Except the harmonic was placed on the greater omentum. We're actually now placing the stapler on the stomach itself. And you want to ensure that equal lengths of the anterior and posterior stomach are taken in by the stapler. You need to make sure that antrum is flat. You need to make sure that the assistant is holding the stomach, the going to be transected side of the stomach with traction, and then the actual stomach that's going to stay with traction. And then you want to make sure that you partially close the stapler to grasp the stomach. So in this diagram here, I've drawn 80 and 20. So the 80 is going to be transected and we're going to remove that from the patient, and the 20 is what's going to stay. And the green line, so you can see the bottom of the green arrow is the placement of the stapler, and then the stapler is going to staple the stomach cranially towards the fundus via the green arrow, towards the angle of His. So just let that sink in. That's quite a lot of information. Okay, and then now we're going to fire the staple. So a black or green cartridge is used for the first 2 staples, and these are staples for larger and thicker parts of tissue. So the bougie or the boogie, so that is placed, so once you fire the staple first, so you fire the first staple via the green arrow, now you place the boogie or bougie into the stomach, as shown in the cartoon, to guide the next few staples and the diameter of the stomach. So you can use a 30 to 40 French bougie placed through the pylorus. And then the second firing is along the border of the lesser curvature blood vessels and bougie outline. So via the green arrow in this diagram, and again, black and green cartridges are used. And then the last 2 firings are using smaller staples for smaller and lesser thick, thinner tissue, simply in pub cartridges. And now you're trying to target the cardia, so the angle of His, the cardia. This is the most difficult to calibrate, so you need to ensure that you're not actually stapling the cardia itself, otherwise the patient can't get food down. And you need to make sure the posterior gastric wall is retracted properly before you staple, and you need to rotate the stomach to check that the stapler is in the right position. So the final firing of the stapler is as discussed. So at the green arrow again in this diagram on the top right, and it's 1 to 2 centimeters proximal to the gastroesophageal junction. So you need to ensure the greater curvature is retracted properly, as discussed before, and you need to ensure that you can see, as highlighted in yellow, the yellow ring, that the stapler has no tissue in between it at the end, as you want to ensure it's in the right place. And then once you cut all that stomach away, so the 80% part in the top right of the diagram in the top right, so the transected stomach is now transected, you use laparoscopic shears to just cut away the end, any attachments to the other part of the stomach. So now we've finished cutting away all the stomach, and you've left 20% of the stomach left, and it's fully stapled with the buttress material on it as well. You want to suture up the cardia using 1 to 2 interrupted Lembert sutures. So I've placed images here, cartoons here to visualize. And then you remove the transected part of the stomach through the left flank port incision, so through a larger diameter port. So the way that that's done is a bite of an uncut free stitch suture is placed, as you can see in the bottom left-hand screenshot that I've taken from a video, and the stomach is pulled into the trocar via that suture needle, and then out of the patient, and then the trocar is removed, and then the fascia, whilst this is being done, the fascia is stretched and pulled so the transected part of the stomach can come out. So now you assess for the integrity, hemostasis, and staples. So this is where the endoscope, so just summarising what we've done, we've induced pneumoperitoneum, we've placed the ports in the correct locations, we placed the laparoscopic instruments into the ports, we've cut away the greater omentum via the harmonic, we have now mobilised the posterior part of the stomach as well, and we have stapled away the stomach. So now you've transected the stomach, you've transected 80% of the stomach, and the bougie or boogie was placed as well to help that. Now you've got 20% of the stomach left, you've taken the transected part of the stomach out of the port, and now you're left with the 20% part of the stomach and the stapled parts. And you want to assess for how well the job was done, essentially. So you my laptop's about to die. Let me just put the so you place the flexible endoscope into the esophagus, so via the mouth into the esophagus, down into the stomach to assess intraluminally how well the job was done, and to see if there are any staples that are not in place or if there's any leakages. And then you also wash the stomach with irrigation fluid to see if there's any leakages. And then you slowly withdraw the flexible endoscope just to have a look at the whole stomach and see if there's any leakages. And then once you've irrigated the stomach, you then put a 19 French plate drain in and drain all that fluid out. And then you remove the Nathanson liver retractor. You suture up the omentum. This is called omentopexy. So you suture the greater omentum back to the now new greater curvature side of the stomach that's left. And this step 19 is not done by every single surgeon, so it's optional. It's called the intraoperative leak test. So this is essentially where you try and test for leakages. So what is used is this dye called methylene blue dye, and you place that in. Air can also be used, and because it's blue, you can see if there are any leakages. But some surgeons don't use this as there's weak evidence to support this test. So there were some studies that had actually shown that when patients were given this methylene blue and there were negative results, so no leakages found intraoperatively, these patients actually developed leakages after. So the question is, how good is this IOLT test, or IOLT? It was also postulated in another research study that this methylene blue dye test, or this air test, IOLT, actually weakens the staple line, increasing the risk of leakages post-operatively. So that's why it's a bit controversial. So now the surgery is finished. not finished yet, but basically everything else is finished. We can close everything up. So the closure is fascially, so fascial closure for the largest port, so the 10 to 12 or the 15mm port, and then skin closure for all the other sites. So here is a link to watch the YouTube video. I'm not going to play it now as it's 12 to 13 minutes long, but feel free to have a watch. And this just outlines all of the steps that I've just explained in a video. So post-operative care. So on the day of the operation, a gastric graft and swallow study is formed to assess for any leakages or strictures. But delayed passage of this contrast doesn't mean that the patient can't leave at the normal time. It could just be due to post-op edema. And then they are admitted for a single night hospital stay. And then the patient is advised to leave with advice via a bariatric dietitian, and then a follow-up in 7 to 10 days, and they are on a stage 2 bariatric diet. So for the follow-up appointments, it's 30 days, 3 months, 6 months, 1 year, and then yearly after that. There's also routine bariatric labs, so assessment for malnutrition, so 6 months, 1 year, and yearly. And then finally, for the anaesthetic point of view, post-operatively, the anaesthetist wants to make sure the patient has sufficient analgesia, as that was very traumatic to go through, especially being a bariatric patient on the operating table. There's a lot that could have gone wrong, but because of the safety measures taken by the MDT, that would have all hopefully gone smoothly. So analgesia to make sure that the patient is not in pain, so it reduces the risk of post-op chest infections as well, and ensures sustained ventilation and pulmonary physiology. So according to the WHO pain ladder, you start with paracetamol, NSAIDs, and then you can progress to IV opioids and local anesthetic at the wound site. You can also give patient-controlled analgesia, so the patient can control their analgesia when they want it, IV opioids. You also need to ensure that the wound is properly taken care of, it's clean, there's no infections, it's not the sutures via the laparoscopic ports are in place and it's not leaking. And you want to make sure DVT prophylaxis, so early post-op ambulation, enoxaparin perhaps if they are suitable for that, compression socks, and all the measures to prevent DVT. You also want to give fluid management, appropriate fluid management, and then extubation only occurs after the patient is hemodynamically stable. And then you want to give supplemental humidified oxygen as well. So the last few points I want to talk about is reinforcement of the staple line. So we talked about the buttress material, as you can see in the diagram. So there's that white material there where the staples are placed. That is part of the stapling process, and that ensures that the staples are properly adhered to the stomach. You can also use another method called oversewing. So the clue is in the name, you oversew or overstaple, but there is an increased complication rate and operative hours to do that. And then you can also use clips, but they're rarely used and only applied to the staple joints or bleeding areas. So the main So the main differentiating factors for LSG between surgeons are I've got to put here, but it's kind of common knowledge, is the port site. So different surgeons like to place different size ports. So they might do a 10 to 12 or they might do a 15. They could also place it in different areas as well, but the cartoon that I showed you before, which is here, is the standard, but some surgeons might do it differently. And the other most important thing is the bougie or boogie size. So there's a range of 32 to 40, but you can also, there's different studies that have shown that using a smaller French boogie increases the leak rate and the weight loss. So a lot of surgeons use the larger one to decrease the chance of a leakage. And So Thank you very much for listening to my talk on LSG. So just to summarize, LSG is a type of bariatric surgery. It is where you cut the stomach vertically and you remove 80% of the stomach, roughly 80%. It's performed laparoscopically, so it's minimally invasive. You make small incisions into the abdomen, you place the ports, you place the laparoscopic instruments, you dissect the greater omentum from the greater curvature of the stomach, then you mobilize the stomach. You can now, because you've mobilized the stomach and cut away the greater omentum, you can staple the stomach. So when the staple occurs, it actually separates the stomach into two, into the 80 and 20 fashion. Then you staple it all the way up via the green lines I showed you in the diagrams, which were here. There. You staple it all the way up to the angle of His, but make sure it's 1 to 2 centimeters away from the gastroesophageal junction or the cardia. And then you remove the stomach via the transected part of the stomach, so the 80% of the stomach, out of the patient using a suture, and you remove that out of the stomach out of the abdomen via a port. And then you perform an omentopexy, so suture the greater omentum back onto the stomach, and you test for leakages. So you can do the optional IOLT test, or you can, in addition to that, you should do put the flexible endoscope down the esophagus into the stomach to test for any leakages and see if there's any leaking. And then you remove that. And then once you do that, you also irrigate the stomach with fluid to test for any leakages. And you drain all that fluid. Then you can suture everything up. So that's using the Lambert sutures. And then you remove everything. So you remove the liver retractor, you remove the ports, and then you close all the incisions made using different types of closures. Postoperatively, you want to ensure that the patient is stable before you do discharge them, and you want to make sure they're released on an appropriate diet, and you refer them to a bariatric dietitian for that, and they'll be looked after by them. And then you want to make sure that they have the correct analgesia and they are stable before they leave. Thank you very much for listening to my talk. If you have any questions, my email is mzyal10@nottingham.ac.uk. Thank you very much.